For the people that I did not have a chance to connect with, at least in our last room, my name is Matt Varon. Dr. Varon, I'm one of the neuromuscular docs here at KU. And so people often have a lot of questions on this topic. I want to make sure that we're able to stay on time, but I also want to be able to answer as many questions as we possibly can. I do have a little bit of a presentation, and so we're going to talk a little bit of the high points about cancer and myositis. And so, as many of you are aware, there is kind of this association between cancer and myositis, and so we'll talk about a few items with that, and then I'd like to open up to questions and just try to get your individual thoughts so we can try to be helpful. And so no disclosures. And so a little bit of background information. You probably have this already. And so we are talking about myositis. And so these are adult onset idiopathic inflammatory myopathies. So idiopathic inflammatory myopathy and myositis are the same thing. These are multi-system autoimmune disorders. Primary attack is of muscle, but there are diverse other manifestations, as a lot of you are probably aware, lungs, skin, and many others. These are associated with an elevated cancer risk. And so for the years before and years after the diagnosis, there is an increased risk of diagnosis with cancer. This has been discussed in the literature for quite some time and has been kind of, I guess, formally defined in the last, I would say 10 to 20, probably 20 years or so. Risk and cancer association varies depending on the type of myositis. And so there is low risk features and there's also high risk features. Not everyone with myositis gets cancer, but certain types of myositis tend to suggest a higher risk of developing cancer. And so that is something that we need to be aware of so that we can identify it early, diagnose it, and treat it appropriately. Some studies suggest that up to a quarter of patients with myositis may ultimately receive a cancer diagnosis. And this is a common cause of death in adults with myositis. You'll notice I've said adults a few different times. The primary focus of our lecture here is on adult onset myositis. I just want to make one small mention. This doesn't really apply to juvenile onset myositis. It does not really have the same cancer risk. Early diagnosis, early recognition of an underlying cancer is super important. Okay. And so which types of myositis? Who is at highest risk? And so, within the different subcategories of myositis, dermatomyositis tends to have the highest risk of cancer. Polymyositis, which as I kind of discussed a little bit in our prior session, is a group that is kind of dwindling a little bit to some degree, is categorized as more intermediate risk. And then immune-mediated necrotizing myopathy, it has some higher risk than the general population, but it's generally felt to be a lower risk than dermato or polymyositis. And keep in mind, when we're talking about risk for cancer, a lot of this, it's a relative risk. So this is a risk above the general population. And then inclusion body myositis, at least as far as we can tell, does not have a strong association with an increased risk of most malignancies. There is this kind of rare association with a type of lymphocytic leukemia, but that's a little bit more detailed topic of discussion. But in general, no increased cancer risk. Within individuals, there are a lot of other features that we can look at to try to establish your risk. And that's a lot of what we're trying to figure out is more or less, what's the risk of finding something? What's the risk of having something else that's either driving or part of this disease process? Certainly, if you have dermatomyositis, you're already in a high-risk category. If you have dermatomyositis and you have antibodies against TIF1 gamma or NXP2 antibodies, these are two antibodies that tend to have an even high risk of associated malignancy. If you are greater than age 40 at onset and you have an aggressive disease, these are also associations. It does not mean you have cancer. It just means that you're in a higher risk category and we need to be very vigilant about looking for it. Dysphagia or very severe skin changes, so cutaneous necrosis, skin ulcers, these are also high-risk features. Polymyositis or immune-mediated necrotizing myopathy, these diagnoses will put you in a little bit lower risk. intermediate risk. And then low risk category are things like overlap and anti-synthetase syndrome, JO1 and anti-SRP antibody associated necrotizing myopathy. Tend to be lower risk for malignancy, and so we don't have to do as much looking necessarily. There's a variety of cancers that are described in association with these conditions, and so these are just a few of them. A lot of what plays into the individual types of cancer is how we go about screening for them, and so and to know that these can present in a variety of different ways. It's not one cancer that someone develops with any particular myositis. It's this kind of general predisposition to cancers. And so solid tumors of all different types, non-solid tumors, hematologic malignancies like leukemia and lymphoma are also very well described. And so we're putting your risks together based on your individual syndrome, symptoms that you've experienced, and some of your lab testing in order to try to figure out how we can keep this from happening. The risk of cancer with myositis tends to be clustered close years before and a few years after the diagnosis. Your risk of cancer in the long term actually improves. And so at least when it comes to myositis-associated cancer, it's something that we typically are expected to see. We typically expect to see within those few years of diagnosis, either before or after diagnosis. And so if you are in one of these high-risk categories, you really should be receiving cancer screening. That's something that's very strongly recommended. If you have dermatomyositis, you really need cancer screening at the time of diagnosis. And you need repeat cancer screening over a period of time. And so the guidelines would suggest probably at least 3 years. There's some evidence that suggests you have a high risk of cancer for even up to 5 years after the diagnosis. And then just of note, after you make it for the first few years after diagnosis, that risk improves quite significantly and it returns to similar to the general population. This is not typically a late association. And so if you have a diagnosis of myositis and you've gone through your typical screening and you're a few years out, the screening guidelines kind of fizzle out. You don't have to continue doing those necessarily. Let me see, make sure I didn't skip a slide. Okay. And so this is kind of a busy slide. I'm going to just talk about this in kind of a very, I would say, light way. And so this is actually one of our screening guidelines. And so there's been a few guidelines over the years, and this is probably the most recent one. And these are more or less the screening guideline and algorithm for looking for cancer in the context of myositis. Keep in mind, this is screening. And so this is, you have a diagnosis of myositis. You have no symptoms of cancer. We don't think you have cancer. We want to make sure you don't have cancer despite not having symptoms. And so we're screening for it. We're looking for it. If at any point you have symptoms that are concerning or suggestive of a problem, we always recommend evaluation for those directly. And so that's no longer screening, that's evaluating a specific symptom. And so depending on your individual type of myositis, depending on the individual risk, this changes more or less what we do. And so if you are low risk myositis, you may not necessarily need any specific screening. And so I will say most of our patients with IBM do not need specific screening aside from typical normal age-appropriate cancer screening. If you fall into one of the intermediate risks, it's going to be kind of down here on the left. So kind of basic screening. So it's a lot of laboratory tests, some basic x-rays and imaging, just to make sure we're not seeing anything suspicious. If you do fall into the higher risk categories, either based on your underlying diagnosis or antibodies, we typically do recommend more. And so these guidelines will refer to this as the enhanced screening, but traditionally this would be doing a CT of chest, abdomen, and pelvis to just look for a cancer that might be there. Doing a mammogram or mammography to look for an underlying breast cancer. Referral for colonoscopy to ensure there is not a colon cancer present. And then oftentimes additional blood testing just to make sure that we're not missing anything. make sure real quick, just want to make sure I'm not missing anything on here. All right. Couple notes on treatment. And so if a cancer is identified, you really have to treat both. It's important that both are treated. And so while the interplay between development of cancer and myositis is complicated, you really do have to end up treating both. And so treating the underlying cancer does not make the myositis go away. You still have myositis that we're going to have to follow and treat in the long term. Okay. And so just a few brief conclusions, and then I'll open it up to a few questions. And so idiopathic inflammatory myopathy, myositis, is associated with an increased risk of cancer. This cancer risk tends to be clustered near the time of diagnosis in the first, couple of years before and then few years after the diagnosis. Your individual risk is based on multiple factors, including the individual subtype of myositis that you have, as well as some of the other either clinical features that I mentioned earlier, rate of progression, skin manifestations, or some of the antibody testing that we do. And then, at least know that we actually, have fairly good screening guidelines that are available. And the goal for all of these is an attempt to ensure that everyone with myositis gets appropriate screening. And so we know that that cancer is a common cause of death in our myositis patients. And so identifying it early is critical in order to ensure adequate treatment. All right. And at least for the formal presentation, that is all I have today. We got a pretty big group here. Let me take a look here at the chat. And if anybody wants to go ahead and open it up to any questions, I'm happy to take any.
Doctor, do you mind sharing your screen? Stop sharing your screen?
Yep. Yeah, absolutely.
And then I can read a couple of questions from the chat.
Sure, that'd be good. Oh no,
Go ahead. What?
I hope I didn't. Did I write BM in my lecture?
No, she was correcting herself.
Oh, okay, perfect.
Correcting herself.
Like, I don't think I talked about it.
Isn't Amcuro conducting a clinical trial with olviprubart for the cancer that IBM patients may be susceptible to?
Sorry, could you repeat that question?
Isn't Amcuro conducting a clinical trial with olviprubart for the cancer that IBM patients may be susceptible to?
Answer that question.
I think
actually.
I've heard.
I think
Yeah,
Dr.
go ahead, Dr. DeMarchi.
Yeah. So that study, and let me take a step back to that question. So this is an excellent presentation, Dr. Varon. All of you now and have heard this wonderful discussion about cancer and myositis. One thing that is hopefully evident to most of you is that those cancers that are associated with myositis do not apply to inclusion body myositis. So all these rules of engagement and that criteria that we developed, I was part of the development team for those criteria. These are excluding IBM because we don't think there's an increased risk of cancer in patients with inclusion body myositis. Now, there's this nice, interesting association of that LGL, which associates with an autoimmune disease in patients with inclusion body myositis. And the target of treatment, which is the second part of your question, now that I clarified IBM and cancer, because I can tell more than half of the attendees have IBM here. So I'm sure you're listening very carefully. Should I get tested for cancer? Don't have to do that. However, when it comes to olviprubart, which is the Amcuro drug that's being currently tested in clinical trials, it's targeting something called KLRG1. Now, KLRG is not targeting the LGL marker, it's targeting the KLRG1. And these cells are terminally differentiated cells. It could be that some of them carry the same marker of the LGL, but it's not necessarily the case. And for that reason, that You're partially correct, but that's not the exact target. The exact target is KLRG1, though it may take care of some of those LGL cells. That's not the primary target.
Thank you very much. Another question in the chat is, in the high-risk factor list, is it dysphagia at time of diagnosis or ongoing dysphagia?
Certainly dysphagia at time of diagnosis as an early presenting symptom would be a high risk factor, would put you into a little bit higher risk for malignancy, and might change how we go about screening. If it's ongoing dysphagia, it still is a risk factor at the onset, and you'll already be within the kind of like screening parameters. And so I don't know that I would say, I don't know that the risk gets higher necessarily over time with that. Since it's already kind of a high risk feature.
Is a positive blood result of MDA5 a firm diagnosis of myositis? And some of these questions that are coming in are more broad.
Yeah.
So
It could certainly be suggestive of myositis, but an antibody alone does not make a diagnosis of myositis. So it certainly requires suggestive symptoms, typical laboratory findings. But yes, in the correct context, with the typical pattern of weakness, typical EMG findings, then yes. That would not only kind of help solidify the diagnosis, but would give you a little bit of information about the diagnosis.
Where do anti-Jo1 patients with dermatomyositis fit in terms of risk?
Well, so typically we would categorize Jo1 within kind of the umbrella of anti-synthetase. You're somewhere between intermediate, but if you're Jo1 and you're labeled as dermatomyositis, I would probably favor just being on the cautious side and performing high risk screening. The absolute worst case scenario is we would hate to know that you are in an elevated risk category, but then not do the appropriate screening and miss a cancer.
Okay, is it thought that the cancer causes the dermatomyositis or the other way around, the DM causes the cancer?
So it's not the underlying mechanism and interplay between the autoimmune disease, the myositis, and the cancer is not really well known. The general thought is that it's probably it may be a paraneoplastic syndrome. And so these occur. And so that's where you have a cancer that causes immune dysregulation, immune dysfunction, and then a subsequent autoimmune disorder. Unfortunately, once you do that, once you start an autoimmune disorder, getting rid of the underlying thing that kicked it off does not stop the disease. Still requires treatment.
Okay, we have some questions coming in that are personalized, and so I'm not certain if they can be answered without the doctor having access to your records, but since I will do, oh, okay. I've been notified that I can send these questions that haven't been answered on to Allie, and then we will get them to the correct people. Thank you so much, Dr. Varon. We really appreciate your time and expertise.
Absolutely. Absolutely. It's my pleasure. Thank you so much for the opportunity. Okay, cool. Sounds good. All right. Hello, everyone. So this is a little bit bigger group than we had just a few minutes ago. And so just